Today we're going to see about Lumen building Protozoa. So this comes under the topic parasitology. Here we're going to see and discuss the overview knowledge about the different protozoa, and we're going to discuss and differentiate the different types of amoeba and the morphology, transmission, life cycle, pathogenesis, clinical manifestation, treatment, and the prevention of the pathogenic amoeba, and also the morphology, transmission, life cycle, pathogenesis, clinical manifestation, treatment, and the prevention of the commensal amoeba, both pathogenic and the commensal amoebas. And the reference for our parasitology is Belisario, Doctor, and Jawad's Microbiology, Bailey and Scott Diagnostic Microbiology book. So protozoa, proto. This means the first one, zoon animal. This may be the unicellular or the multicellular metazoan. This protozoa has a nucleus, cytoplasm, and the organelle. The unique feature is their mode of locomotion, cilia, flagella, pseudopods. They want to live in a wet environment for feeding, locomotion, osmoregulation, and the reproduction. The free living organisms, they are commensal or the parasitic. Cilia, amoeba, and the flagella. Cilia, this has the many short finger-like projections, and the amoeba, they don't have the irregular shape, and the flagella, they have the one flagellum at one end. Euglenoid flagellum, paramecium cilia, and the amoeba pseudopodia. These are the major example for the each type of the protozoan. Here we're going to see the stages of the protozoa: trophocyte and cyst. Trophocytes, these are the vegetative state, feeding, and the invasive one. They are diagnostic stage. And cyst, they are resistant to the changes in the environment. They are infective stage, the typical fecal oral life cycle. Cyst, they passed in the feces, they have resistant, they are infective. While trophocyte, they help in feeding, motile, and the replication. The trophocyte is converted into encystment, then cyst, then excitation is converted to the trophocyte. Phylum Protozoa. The protozoa is converted into Rhizopoda, Ciliata, Flagella, Sporozoa, and their classification is converted into amoeba, paramecium, and the euglena. Different kinds of amoeba. Parasitic amoeba, only one. Entamoeba histolytica, commensal amoeba, free-living amoeba, Naegleria, and the acanthamoeba species. Parasitic amoeba, Entamoeba histolytica. Epidemiology, the third most important parasite next to the malaria and schistosomiasis. Humans, they are the major reservoir, the only pathogenic amoeba in humans. Transmission, they are fecal oral route. Increase the incidence in the poor sanitation area, crowded places, and low socio-economic. They have the cultural habits that involve the poor hygiene. Morphology, pseudopod forming non-flagellated protozoan parasite. Pseudo, this means false. Pod, this means parasite. They have the false shape. They are the most invasive among the amoebas. This histolytica, cyst is the infective stage. Same morphology as with the E. dispar and the E. moshkowski. While speaking about the trophocyte morphology, they are around 12 to 60 micrometer. They are highly motile, progressive directional movement, clear glass-like ectoplasm by granular endoplasm, one nuclei with the central karyosome, and even peripheral chromatin. Ingested RBC in the cytoplasm, erythrophagocytosis. While speaking about the life cycle, the cyst or the trophocytes are passed in feces. Cyst, the infective stage, infected by an individual, ingested by an individual. The cysts are resistant to acid of stomach. The intestine intervent excitation since pH is alkaline. Then some trophocytes in the intestinal causes the intestinal diseases like colitis. They invade the blood vessel. Then the trophocytes gain entry the blood vessel, so they spread outside the intestine and they causes the extra intestinal manifestation. At last, we can go for the diagnostic stage of the trophocytes. Pathogenesis, that is the intestine, and they move to the extraintestinal tract. Entamoeba histolytica trophocytes, they adhere to the intestinal cell by galactose inhibitable galactine. The amoebic phagocytosis, making a pore or small bite to the intestinal cell. Invasion, flask-like ulcer, cysteine protease. Activation of the caspase 3, apoptotic intestinal cell death, lungs, liver and brain. Clinical manifestation, asymptomatic luminal cyst passes. They infect the other people. Amoebic colitis, abdominal pain, diarrhea, fever, red mucus stool and amoebic dysentery 4 forms. Acute dysentery, fulminating colitis, amoebic appendicitis, amoeba of colon. Amoebic liver abscess. The most common extraintestinal form of amoebiasis, auricular pain, fever of less than 2 weeks. If greater than 2 weeks of fever, they causes a wasting, weight loss, and older patient have lots of problems. In the center of abscess, they causes the necrotic tissues. In case of the peripheral, the active amoebas try to spread around the liver. Usually affect the right upper lobe. The other extraintestinal amoebiasis is the pleuropulmonary, genital and the cutaneous brain. These are the most affecting areas in the amoebic liver abscess. Intestinal perforation. This is the most serious complication by the amoebiasis. Secondary bacteria peritonitis. That also causes the dehydration due to the diarrhea. They also causes the abscess rupture, pleura, pericardium, peritoneum. And the secondary amoebic meningoencephalitis, they are more seen in the neonatal status. Differential diagnosis, bacillary dysentery, inflammatory bowel disease, irritable bowel syndrome and the pyogenic liver abscess. Amoebic dysentery and the bacillary dysentery, the type of stool, foul smelling with the blood and the mucus resembling sago grain. In case of bacillary, they are non-smelling blood and the mucus strain resembling the current jelly-like feature. The frequency here in amoeba is not much and in the bacillary they are marked. In case of amount, they are bulky and scanty in the bacillary. Fever is rare in the amoebic while in bacillary they are usual. But in the amoebic they have the many complications. In bacillary dysentery they have the very few complications. Here we can go for the lab diagnosis. In the amoeba they have stool which is bulky and acidic. In bacillary they have scanty and alkaline one. Scanty exudate, example pus and blood. Massive exudate, that is the pus cells, blood. Charcot-laden crystals, they are present in the amoebic dysentery and amoebic trophocytes, they are present. And amoebic trophocytes and the Charcot crystals, they are absent in the bacillary dysentery. Diagnostic, direct fever smear with NSS. Fresh watery stool within the 30 minutes, trophocytes and the RBC may add the staining. May see the Charcot-laden crystals, non-diagnostic one. Concentration tests like formalin, ether or ethyl acetate concentration test or the methylate iodine formalin concentration test for cyst. Serum antibodies, ELISA, CIE, IHAT, this is for ALA. Imaging test like CT scan, MRI and UTZ. Look for the presence of abscess especially in the right upper lobe. They are round and oval hypoechoic with the wall echoes. Must be differentiated with the pyogenic liver abscess like aspiration. Speaking about the treatment for the asymptomatic passage of a cyst from the intestine, dialysate furoate need to follow up for the possible invasive symptoms. For intestinal with the extraintestinal symptom, metronidazole. For PX with the ALA who did not respond with the metronidazole, percutaneous drainage can be done. Drainage can be done through the lung for the abscess using the drainage catheter and in the liver and also the gallbladder. For control, we can do the sanitation like safe food and the water products, proper disposal of the human feces and the latrines. We can also use the screening of the food handlers and vaccine if it is possible. Generalites, like all of the commensal amoebas inhabit the large intestine, example gingivalis, and all of them develop into cystic stage except gingivalis. Mistaken for E. histolytica, they avoid the unnecessary management. Indicate the contamination of food and water for the food handlers. Transmission, the ingestion of the mature cyst through the contaminated food and water or the fomites. Excitation in the small intestine tropocytes due to the alkaline form environment. Tropocytes, they are the non-invasive and does not cause the disease. Binary fission is possible as a form of reproduction. Incystation in the large intestine before passing out to infect another host. Management, diagnostic stool examination, direct fecal smear for the watery stool, fecal and the zinc sulfate fluoridation for the formed stool, oral gingival swab for the gingivalis. Treatment, they are not needed. Prevention, proper disposal of the human excreta or the proper hygiene. Intermeba display, morphologically the same with the histolytica, different DNA and or RNA. Use the isoenzyme pattern, ELISA or PCR to differentiate it. Entamoeba hartmanni, same but smaller than the Entamoeba histolytica. The tropocytes, they measure 3 to 12 mm and uninucleated with the central karyosome. No ingested RBC since they are commensal amoeba. They are common in HIV, MSM immigrants or travelers from the endemic countries. System, they measure 4 to 10 mm, quadrinucleated, rod-shaped chromatoidal material with rounded or the square ends. Entamoeba coli, tropocyte, they are more vacuolated endoplasm with the bacteria, narrower, less differentiated ectoplasm, broader and the blunter pseudopodia, more sluggish and undirected movements. Thicker, irregular peripheral chromatin with large eccentric karyosome in the nucleus. Entamoeba coli, cyst, they are larger size 10 to 35 mm, octonucleated with the eccentrically located karyosome, uneven peripheral chromatin, no granular cytoplasm, splinter-like chromatoidal bodies, iodine staining reveals the dark staining perinuclear masses which are glycogen. While speaking about the cyst of Entamoeba coli, they are larger size 10 to 35 mm autonucleated as I said before. The cyst morphology. Entamoeba histolytica, tropocyte Entamoeba coli. Can we differentiate this one? 12 to 60 micrometer, 15 to 50 millimicrometer. Long and finger-like projections are found, broader and the blunted projections. Progressive directional, sluggish, unidirectional for the motility. While speaking about the nucleus, they are centrally located karyosome. They are eccentric karyosome in the nucleus. While speaking about the cytoplasm, RPC, plain looking ectoplasm. Dirty vacuolated ectoplasm. While speaking about the cyst, Entamoeba histolytica and the Entamoeba coli, size is 10 to 20 micrometer, 12 to 25 micrometer. The nuclear membrane is thin, even the peripheral chromatin, they are thick, uneven peripheral chromatin. While speaking about the nucleus, there are 4 nucleus present in Entamoeba coli. There are 6 to 8. Sausage shaped or the cigar shaped chromatid bodies, sphincter like, broomstick like chromatid bodies. Cytoplasm highly refractable cyst wall, they are more granular. Entamoeba coli, they are pigs and monkeys. Can be caused. Entamoeba gingivalis, which are present in gums and teeth, reside in mouth, gingival pockets or base of teeth. Transmission by the direct contact or kissing, sharing the utensils. Tropocyte size is 10 to 20 mm. Moves quickly, numerous blunt pseudopodia. Food vacuoles contain the cellular debris and the bacteria. Uninucleated with the central karyosome and even the peripheral chromatin. No cyst can be done here. Morphology, the Entamoeba coli, Entamoeba hartmanni, Entamoeba polacki, Indolimax nana, They are generally considered non-pathogenic and reside in the large intestine of the human host. They inhibit the colon and also be found in the appendix. Tropocytes 88 to 10 μm move by the pseudopodia and may reach the size of up to 30 μm during the locomotion. Feed exclusively on the bacteria and divide by the binary fission. Cysts, they are oval and very small. They typically contain 4 nuclei. As I said before, the cysts are excreted in the fetus may survive up to 2 weeks when incubated at the room temperature and for up to 2 months at the lower temperature. Tropocytes may survive in stool for up to 1 day when the feces is incubated at the room temperature. After ingestion, the amoeba exists by escaping through a pore in the cyst wall divided by the successive cytoplasmic bipartition into uninucleate amoeba and turn into the trophic stage. Transmitted through the fecal oral contamination of the food or water. Most carriers are found in the Africa and South America. Considered non-pathogenic commensal protozoan parasiting the human colon. And the diagnostic and the treatment for this is gingivalis is the microscopy of the cyst. Tropocytes are rarely observed. Metronidazole and the difetrazoone can be given. They are non-pathogenic parasitic amoeba. They are commonly found in the large intestine of human, pigs and other mammals. They are worldwide distribution. Tropocytes, they are 9 to 14 mm in diameter, has a single nucleus and prominent for the nuclear endosperm and many cytoplasmic vacuoles. Cyst, they are the infective stage, 8 to 10 mm in diameter with a thick wall and a large glycogen vacuole that stains stapler with the iodine. Cysts have the oval-shaped single nucleus with the prominent nuclear endosome. Large single glycogen-filled vacuole called iodinophilus vacuole.